Some of our learning objectives for the webinar is to understand the current context of cis and trans women who are most impacted by HIV through a social determinants of health lens. We hope that we're able to gain a better understanding of what HIV prevention options are available for cis and trans women in Ontario specifically. We also are learning how to navigate conversations about PrEP, PEP, PIP, and sexual health with cis and trans women. Developing an intersectional understanding of when these options are suitable for cis and trans women. And also, we hope that we're able to develop skills to help increase cis and trans women's awareness of and access to these tools. So I'm going to pass it over to Molly, who is going to be looking specifically at how HIV looks like in Ontario in terms of cis and trans women.
I'm just going to share my screen. Can you see that okay?
Yes.
Yes.
Great. Thanks so much, Cassandra. And thanks everyone for doing the poll. It's really helpful to know who's here and really exciting to have this conversation with everyone here together. As we consider our shared work to ensure cis and trans women have knowledge about HIV prevention technologies in Ontario and beyond, it's important to understand who is the most impacted by HIV. I'm going to be speaking specifically about Ontario, given that both the OHTN and WHAI are located in Ontario, and we didn't actually anticipate as much participation from outside Ontario, but we're very happy to have folks here from outside of Ontario. And I imagine that many of the health inequities and conversations about equity can be linked to communities outside of Canada or outside of Ontario as well, and even more significantly in northern and rural communities. So just to jump into some of the numbers, in Ontario, there are over 22,000 people living with HIV currently, and over 4,000 of those are cis women. And I'm going to speak specifically to trans women in a minute, but just to sort of delve into this a little bit more. We know that 20 to 25% of new diagnoses in Ontario are women annually. So this is from the Ontario Epidemiological Surveillance Study, or OHTN, which is a project of the OHTN where Cassandra works. So that's 1 in 4 or 1 in 5 of all new diagnoses. And we know that women don't face equitable realities that impact their risk. Some women are definitely disproportionately impacted. So 44% of cis women diagnosed for the first time with HIV are Black women in recent years. And of course, this is very disproportionate to the number of Black people that live in Ontario, which is about 5.5% of the entire population. That includes all genders, according to 2021 census data. And this really points to a range of factors that put Black women in particular at disproportionate risk. So we know that linking work to churches and cultural centers and settlement services, refugee services can help to bridge relationships. But more than anything, we know that building trusting relationships with Black communities, especially given the history of medical experimentation and violence, that leads really to deep levels of mistrust. So this means that working alongside Black women is really critical to our work here. While 13% of women diagnosed with HIV for the first time in 2020 were Indigenous women, Indigenous people make up just under 3% of the population in Ontario, and that's actually the largest population in Canada from my read of the most recent stats. Again, showing significantly disproportionate impact of HIV for Indigenous women. And we see this as being especially heightened in more northern regions in Ontario, such as Thunder Bay and Kenora. This is also from from OHTN and the OHTN. Again, these statistics show us the importance of working alongside Indigenous communities and advocating for their leadership in creating and implementing HIV prevention and care work with Indigenous communities, rooted in local and cultural practices that honor Indigenous women's autonomy and choice and wisdom and their relationships with others in the community. In most recent data from 2020, 25% of cis women newly diagnosed were through injection drug use. I want to note that in many communities, Indigenous, Black, and Brown communities have been excluded from many harm reduction programs. or are underrepresented in the usage of those programs, meaning that they're also not reached through many of the local HIV prevention strategies within those programs. You'll note in the slide the use of language of drugs and substances to ensure we're including substances that may not generally be included in drugs or in harm reduction rhetoric. This is done with input and based on cultural norms from Black, Brown, and Asian and Indigenous communities. An example of this would be alcohol, knowing that this is often left out of harm reduction programs, which means that populations who consume alcohol as a primary substance are often or sometimes structurally excluded from harm reduction programs, and in turn, the sexual health and HIV prevention messaging that go with those. This is not to say that alcohol and other substances directly impact HIV risk per se, but more the access to care and support through those programs is reduced. Finally, and really importantly, for us to be working harder to build our knowledge and understanding of, we know that trans women are more than 10 times likely to report being diagnosed with HIV, which is again from OHTN. I want to note that how we collect information about trans women and HIV in Ontario has changed over the past few years. So we're still building our knowledge and understanding of risk factors and rates. And it's so important for us to continue to build this work in Ontario and beyond. I also want to acknowledge that this number does not overtly include Two-Spirit and other non-binary people, and it's important to work alongside these communities for us to strengthen our understanding of these realities. And with that, I just want to give a sort of shout out to TWIRI, or the Trans Women HIV Research Institute, which you can look to for more information. They've done a great job of amplifying the voices and experiences of trans women. I want to highlight that approximately 50% of women living with HIV have reported experiences of intimate partner violence. This is from 2017, which intersects deeply with the other populations I've just highlighted, especially trans, Indigenous, and Black women, and also women who use drugs. I also want to highlight that almost 10% of women living with HIV in an Ontario, an OHTN cohort study have experienced incarceration, which again, especially impacts the populations I've talked about, thinking about the growing over-incarceration of Black and Indigenous women, which reminds us of the critical importance of looking to these groups for input and leadership in our HIV prevention work. So these statistics, I want to remind us, are not just statistics, but are really human and about humans, and require us to think about health equity in a really human way. They remind us about asking really important questions, such as who has access and who doesn't, how our structures and our strategies promote access for some and create barriers for others, and how we can work alongside these communities to navigate systems together and build supportive and thoughtful pathways. And I want to remind us also that each of us has an onus and responsibility to be doing this work in ways that work for people in our community. In terms of how many women are on PrEP in Ontario, in a published paper from 2023 that I'll highlight, Lauren, who's one of our guest speakers today, her team published this paper. It highlights the HIV prevention efforts over the past few years have increased, and that HIV rates in Ontario have decreased among men who have sex with men. And by extension, the proportion of HIV diagnoses among cis and trans women has increased, meaning that we need to think it together about strategies to reach these populations in an equitable way and in ways that work for those populations. So in terms of the numbers, cis women account for about 3% only of people on PrEP in Ontario, compared to the 20 to 25% I mentioned of new diagnoses, which is the ratio of a new diagnosis that will continue to grow disproportionately without thoughtful and strategic work on all of our parts. And these stats really demonstrate the need to build awareness among cis and trans women, two-spirited and non-binary people, along with providers. And really importantly, because I think the interface often for many of these populations is through community outreach workers and community support workers and care workers. We've seen through research that the inclusion of PrEP and I would suggest also the inclusion of PIP and PEP services has shown improved access when integrated into gender-affirming programs for trans women, to STI screening and safer sex supply programs, and to mobile syringe programs for women who use drugs and substances. And just a quote at the bottom there, that we need education for service providers about women and HIV, PrEP, PAP, and PIP, U=U, and testing. There's a lack of awareness, and it's so important for women, so women can find out more, and so that we can all work together.
My name, as mentioned, is Lauren Orser, and I'm going to be touching a little bit on HIV prevention options for women, and also drawing in some of my perspectives and experiences as a frontline nurse working in sexual health and harm reduction at the clinics here in Ottawa. So we'll start things off with a bit of an overview about what PrEP is and how it works. PrEP, first and foremost, is indicated for use in women who are HIV negative. So anybody who is considering starting PrEP would actually need to do an HIV blood test within 2 weeks of starting the medications, just to make sure it's safe for them. In terms of the regimen, PrEP basically involves 2 HIV medications in 1 tablet that's taken every day ongoing. In the United States, they also have an option for a long-acting PrEP, which is an injectable kind of taken once a month, which is reported to have the same protective effects as the oral pill. Right now, it hasn't quite been approved in Canada, but it's certainly something that we're hoping to add to the array of treatment or prevention options for women soon. The best evidence that we have in terms of PrEP use for women is actually with the daily PrEP medications, as it involves people taking it at the same time every day ongoing to have the highest preventative effect. There is also some evidence that talks about episodic PrEP or PrEP on demand, which essentially involves people taking 2 doses of PrEP medications before a sexual contact, and then 1 dose once a day for 2 days afterwards. Of the evidence that we have for episodic PrEP right now, though, it hasn't quite been studied in women, so we don't know exactly what that effect would be. But what we do know from the studies with MSM is that it should be around 86%. In terms of the effectiveness of the daily PrEP, which is where we have a lot of our evidence for women, is that we know it's at least 90%, particularly when it's taken as prescribed at the same time every day. And for women and other people who inject drugs, it's somewhere around 74%. So in terms of PrEP indications, the current PrEP guidelines in Canada are quite limited in terms of what they recommend for PrEP in women. Right now, these guidelines recommend that PrEP be offered to HIV negative women who have positive partners that have a detectable viral load, so above 200 copies, as well as for HIV negative women who have partners who are at lower risk of transmitting HIV, so perhaps have a low but not undetectable viral load, as well as for women who are sharing needles or other equipment for injecting drugs. But as Molly mentioned, having these narrow guidelines has resulted in a really low uptake of PrEP among women. So from the most recent data we have here in Ontario is that only about 2.6% of all PrEP prescriptions were given to women compared to over 90% in men. So kind of looking at uptake in general so far in Ontario, it really shows us that we need to change the way that we think about PrEP for women and to increase awareness among women about its risks and benefits, or its utilities and benefits. One challenge to assessing risk in women is that the risk factors for HIV are a little bit more subtle and perhaps not as easy to identify compared to those for men who have sex with men, which largely focus on HIV risk after a STI diagnosis. So in Ottawa, we actually did a review of HIV prevention uptake for women who had accessed nurse-led PrEP services, and found that the majority of women who actually accepted PrEP had more subjective risk factors, and most in our sample were actually women who inject drugs. When we looked at some of those more like objective risk factors that we see in guidelines, like an STI diagnosis or an HIV exposure, women in our sample were actually more likely to have declined PrEP based on this fact. So in recognition of some of the sort of like nuanced or layered risk factors for women, the OHTN, in collaboration with the Prep for Women Advisory Committee, released some recommendations for PrEP in women. So in addition to the items that are listed in the current PrEP guidelines, this guide actually recommends that PrEP really be offered to any woman who comes in requesting it, regardless of what they report their risk factors to be. In addition, consideration should also be made for women who have personal or more direct risk factors, so perhaps are engaging in condomless sex, who have had a recent STI diagnosis of any kind, who are engaging in sex work, particularly those who are engaging in survival sex, or are engaging in sex for money, drugs, shelter, or perhaps are being trafficked, as well as for women who are using drugs, even if they report not sharing any needles or other equipment. PrEP should also be considered to offer in women with more indirect or kind of partner-specific risk factors. So perhaps have partners who maybe aren't aware of their HIV status, who might be using injection drugs, who identify as a man who has sex with men, as well as for women who are experiencing intimate partner violence. Consideration can also be made for offering PrEP to trans women as well, following the guidelines for men who have sex with men from the Canadian guidelines. So we're looking at those more specific risk factors of a rectal, chlamydia or gonorrhea infection, syphilis infection, any recent PEP use, or a HEARI MSM score 11 or higher. Providers also need to be aware of some of the benefits and barriers to PrEP and other HIV prevention services among women, and to really use this information to help guide conversations that they have. So I want to recognize that I am not in a position to speak on behalf of the lived realities or experiences of all women, certainly all women that are at risk for HIV, but there are a lot of insights that have been gathered by researchers within these specific communities that can be really useful to help shed light on what some of these experiences are when you're having these conversations with women. So when it comes to some of the benefits of PrEP, some women have talked about feeling a sense of safety and security using PrEP, knowing that they would be protected against HIV, even if they were to engage in quote unquote riskier behaviors like condomless sex or drug use. Women experiencing intimate partner violence as well, are feeling a lot of an extra sense of control over factors in their life that otherwise can feel quite uncontrollable. So not having to negotiate with their partners about safer sex or about their health, or having to rely on somebody else for prevention. Certainly in the conversations that I've had with women who are using PrEP, they talk about it as being a really freeing experience for them, that it kind of helps alleviate a lot of like the worries or anxieties related to HIV. And in the context particularly of women with intersectional or layered aspects to their life, they're managing housing, financial, food insecurities, that, being able to eliminate the possibility of HIV or a potential exposure is just like one kind of thing off their plate. And certainly was something that really they spoke about being a benefit to them. PrEP also makes women feel empowered, especially when information and services are culturally focused and when they happen in women's own communities. As well, having peer educators, peer support workers, and community service workers who belong or within these own communities can help make PrEP feel more relatable to women. So recognizing that, blanket information about PrEP is useful, but really considering having like more specific resources tailored to women, because prevention affects different groups in different ways. So having more specific resources for trans women, Black women, Indigenous women to help with sharing that information and making it accessible. PrEP can also be facilitated by having access to really low barrier services that don't require a lot of like medical follow-up or a lot of extra effort. So, having PrEP being part of like the regular hormone therapy visits for trans women, or having like PrEP pop-ups or drop-in clinics in community organizations or AIDS service organizations can be really useful to get people engaged. In terms of some of the barriers to PrEP, women have reported some concerns related to medication use in general. So cost is certainly one consideration and can be one barrier to PrEP use, as well as the cost associated with some of the tests that sometimes need to be run for PrEP monitoring for women who maybe don't have access to health insurance. There's also concerns about potential side effects, particularly when those can cause maybe more like flu-like symptoms, so fever or stomach upset, nausea, that might impact people's daily activities, as well as concerns with potential for interactions with other medications like contraception, or for trans women, concerns about interactions with their hormone replacement therapy. It's also extremely important for us as providers to acknowledge that many groups of women are hesitant to engage with the healthcare system in general due to fears or actual experiences of stigma, racism, judgment, stereotyping in healthcare settings, or by having healthcare providers pushing Western ideals or values about what health or prevention looks like. For women also experiencing intimate partner violence, even just getting to an appointment could sometimes be challenging, especially if their partners are maybe withholding health insurance cards, or if they have to find a safe place to store the medications in their home in general. There's also concerns about misperceptions about PrEP, that it might be associated with ideas of promiscuity or people who are riskier than others. In my experience, working with women who have had a recent HIV exposure, one of the biggest barriers was that they were concerned that if someone saw their PrEP medication, they would assume that they're positive. So for them, that was enough of a deterrent to not want to use it. There's also limited access to kind of PrEP-specific clinical services, particularly for women living in more rural or remote areas or who are underhoused or homeless. That accessing basic things like the internet, the phone, going to a lab or a pharmacy can be, a big mitigating factor in initiating PrEP. And lastly, there's, the issue or concern that kind of brings us all today is that there's kind of a lack of awareness or lack of practices, particularly in healthcare settings. So one big step in trying to increase uptake or awareness in women is to kind of increase these conversations in clinical settings. In my own practice, I really treat PrEP discussions with women like I would treat conversations about contraception or even smoking cessation, which is basically to offer information to them at every clinical visit. In Ottawa, we did a review of people whom we had offered PrEP to multiple times and found that when we offered it, at every time we saw them, that in some cases people's responses changed as their life circumstances changed. So, some people who initially declined said no. The next time we offered it, they said yes. Or someone who initially accepted it, but just had other stuff going on in their life and PrEP wasn't able to be a priority. The next time we talked about it, they accepted the referral again. So that was the opportunity for us to kind of relink them back to care. So kind of using this approach can be a really useful strategy and a really simple strategy to help get information about PrEP and other prevention options into the hands of women for them to consider at a later time. Certainly, because we know how effective PrEP is, I tend to offer it as the first line option. But PrEP isn't for everybody, and it isn't, the best option for every woman. There can be a lot of factors into to using PrEP or to being able to access PrEP in terms of some of those barriers we talked about. So anytime a woman does decline PrEP, it's not the end of the conversation. I always make sure that I provide information about other prevention options like routine HIV screening, access to free condoms, and information on post-exposure prophylaxis or PEP. So PEP in a nutshell involves the use of 3 HIV medications that are taken for 28 days after a potential HIV exposure. And for PEP to be most effective, it needs to be started within the first 24 hours after a contact up to 72 hours. So PEP is most commonly given in like an emergency scenario. So outside of Ottawa, where we actually have like a community-based nurse-led clinic, most people have to go to the emergency department where they would get the first few days of their medications and then have to follow up with the specialist after a few days. So it can be quite a cumbersome way to access HIV prevention services to have to go through like an ER. So there is some research actually happening right now in Toronto that's looking at more of a person-driven PEP approach. So PIP or PEP in pocket or PIP. So basically this is where people would see their healthcare provider and get a prescription or multiple prescriptions for PEP in advance, where they would just go to the pharmacy and pick up the medications when they need it. So this approach can be really useful because it kind of alleviates that element of crisis or emergency where they can just access in a pharmacy, and also gives people time to kind of sort out insurance information and get a really good understanding of the medications ahead of time. In terms of the effectiveness of PEP, it is estimated to be at least around 80%, with the effectiveness kind of going down the later it started after a potential exposure. For PIP, the research is underway, so we don't have, exact estimates, particularly in women, but we can, because it's the same kind of medication and same structure that we would use for PrEP, we can, safely assume that it would be very close in effectiveness. So kind of two different options, certainly to provide to women where PrEP maybe isn't what they want or isn't the best fit for them at the time. Certainly for anybody who starts PEP, our recommendation is that they do kind of a transition, if possible, directly to PrEP. So that would be kind of the day after they finish that 28-day course of PEP, which when we implemented this process in Ottawa, it actually brought the seroconversion rate for HIV from a new exposure after PEP from about 8.5% to 0%. And finally, one kind of last strategy to get PrEP or get HIV prevention information kind of into the hands of women is to also incorporate it into some of the online health services that are kind of becoming more and more common. So this is a screenshot from the checkout of the getakit.ca website, which is an online testing service that offers HIV self-testing all across Canada, and in some areas of Ontario actually offers full STI testing. So basically women would log on, complete kind of a few questions, which helps assess their risk. And based on those responses, they would offer, a full suite of STI testing, the same that you would do in a clinic. But the service also, provides recommendations and links to information on where women can access referrals and information about things like contraception, naloxone, or so it's actually just like a direct link that doesn't require anybody to disclose any information to healthcare providers or have any concerns around there, that they can just click on the link and get linked to PrEP right away. So as we wrap up kind of my portion here, some key takeaways to share would be to kind of use to lower the threshold for how we think about risk in women. And to use some of the updated guidance from the OHTN in terms of like how and to whom PrEP should be offered to for women. And just to kind of treat PrEP discussions like you would treat discussions that you would have about any kind of preventative health services. So smoking cessation, contraception, give the information every time you see them, offer a referral, and certainly provide resources and information about other prevention options for women who decline. So things like PEP, PIPs, condoms, and access to other STI and routine testing, and to really tailor the interventions that you're offering to women based on what their risk is and what their individual life circumstance is. While PrEP we have the most evidence for, certainly it's not something that's going to be most comfortable for everyone. So kind of tailoring it based on what women need and how accessible it can be for them.
Really lovely to see such a great gathering of people from so many different environments and settings. And so some of this may be a little bit similar to what Lauren presented. And I also want to always disclose that I'm definitely speaking a lot from my opinion and from the evidence. So I think I have maybe some privilege being able to be a nurse practitioner and therefore a prescriber, in that I'm able to interpret guidelines as guidelines, and I can work outside the guidelines if that's what I would like to do, if that's what's best serves people. So I wanted to just start, yes, to nerd out a little bit, but also just to say that it's really important that we understand how medications work. Because if we don't understand how medications work, then we can't really explain to people how they work, right? And there's certainly a lot of trepidation, especially in COVID and vaccination, around what medications do, what vaccines do. And so I think it's just really important that everyone knows what the medications, whether it's in PrEP or PEP, or if we're using it in PIP, actually do and how it works. So HIV medications, and as you know, these medications are also used in HIV treatment, actually directly target the virus. So if you think about how prevention works, it doesn't prevent the virus from entering the body. It prevents the virus from replicating. And so that's really important when we think about tissues, and I'll get to that in a second, about how medications work in different tissues. And so I think counseling is really important in terms of how you're counseling folks that might use these medications, and to say that area of exposure matters. And so in the vagina or front hole, depending on how people might give language to their anatomy, people would need to be on PrEP for 21 days. And then in terms of anal or rectal exposure, 7 days. Okay, and then I think some other grounding for my talk today is really around understanding the numbers and how we might think about the need and absolute necessity for these conversations. I think Molly painted a really unfortunate picture around seroconversion of HIV in women, and that's across Canada. I was at a conference for folks who use drugs, and I met a RN from Alberta who told me that in the last 1 month in her outreach activities, 3 women had seroconverted, right? So for sure, we're not doing a great job. So we need to really understand what's been happening. So it's not all a bad news story, right? The good news is, we finally got PrEP approved in Canada. It was 2 years after the US. That's a very long time. And PrEP prescriptions are going up for sure. They're not equal. You can see there from the data that the terminology used here is males and females, and that's usually related to administrative data and the fact that male-female is usually what's listed on the health card. So there's an absolute inequity here. You can see it around access and prescription, but I would also be really critical of any kind of prescribing data because it's usually based on a very incomplete database. I really love and adore this study from Women in HIV/AIDS Initiative, because this really gets to the crux of what we're talking about today. How do we have these conversations? What's known in this space? And Lauren has also done some really important work in this space in Ottawa. And just to go through some of the numbers, that 365 participants in this study did not know about PrEP, right? And so again, sample size matters, but whether it's PrEP or U equals U or knowing about self-testing, people don't know that these options are available, and that's not great. I also just want to set the stage a little bit by discussing a lot of work that has been done in the US, and the US has done far more work among PrEP and PrEP uptake in women than we have, and all populations, adolescents that are at risk as well. And so to say that there's this terminology called PrEP to need ratio. And again, this seroconversion piece that's happening in Canada really matters in this context. And the PrEP to need ratio in the US is 5 times lower among women. Say what you will about US and US healthcare system, but prevention is always on the radar in the US. They do a way better job with vaccinations, vaccine recommendations. They do far more outreach and with PrEP and PEP and PIP. among, for sure, men who have sex with men and also women. But even so, women have a lower awareness of PrEP, ranging from 0 to around 30% in surveys that have been conducted in the US. And I think from some of the qualitative research, which has been so powerful, is that women are so frustrated that they haven't been offered PrEP. Even if they didn't know about it, they're actually really frustrated that whether it's community outreach, healthcare providers, whomever they're interacting with, haven't discussed it with them, haven't provided it as an option, unless they specifically identify as someone who's having sex with an HIV positive partner, or overtly saying, yes, I'm at extremely high risk because I engage in sex work. And we can't ask that of the folks that we're seeing. We can't ask people and expect people to disclose so openly, so quickly. So I'm going to be really critical of the current Canadian guideline. It was published in 2018. And so while I think it's a fairly reasonable resource for folks that are newly looking to gain information in this space, I would really be very, very critical of it. So I would like to say that low quality evidence does not mean no evidence. It means the studies are really difficult to do, and that's why good evidence doesn't exist. It doesn't mean we shouldn't do it. It doesn't mean we shouldn't do it off-label. It doesn't mean we shouldn't present it as an option. So for all infectious diseases in Canada, I usually point folks to CDC resources because they update them far more frequently. And they're much more equitable in terms of how people access care and what we should be discussing. So this is an algorithm from the CDC, and I know it has a lot of different sort of spaces and takes you through a whole different pathway, but I want you to look at the bottom, and I'm going to highlight that every single option leads to prescribe PrEP or discuss PrEP if requested. There is no situation, irrespective of gender, irrespective of condom use, irrespective of types of partners, where if people are having sex or plan to have sex, whatever that means to them, the next year, the next 6 months, however you look at it, discuss HIV pre-exposure prophylaxis if there's sexual exposure. And then I'm just going to flip to say, also think about discussing PEP and PIP. As Lauren mentioned, PIP is a really important option for people to be able to have their own health in their own hands. This is also true of people who use drugs. Every single pathway leads to prescribe PrEP if requested, and then I'll just add, discuss PEP, discuss PIP. I think for a community of group people here who might be in direct frontline roles, might be having these conversations with women, might be healthcare providers, it's really important that you feel really comfortable to discuss these things and really understand how they work and what they do, and to appreciate that things are not perfect in healthcare, and that's okay. So just as an example, I think if we're thinking about places like overdose prevention or supervised injection among people who use drugs, these are good spaces to talk about PrEP, PEP, and PIP, especially among women, because they might actually be accessing these services. And if they do, and they may or may not go for blood work in line with what the guidelines say, that's okay, right? This is absolutely harm reduction. So we can't expect perfect adherence to going for blood week, as Lauren said, 2 weeks before and all these things. It doesn't always fit with people's lives. We have to be flexible. We also have to be flexible that although that pathway leads to describe PrEP, discuss PEP, discuss PIP, as Lauren suggested, lots of people don't want to do these things. It's a huge commitment to be on medication. And people should also know that they have lots of other options, testing frequently, using some kind of barrier protection. And then as has been discussed, that undetectable equals untransmittable. So if they have a positive partner, or they have partners who are positive, but they're undetectable, the risk of HIV acquisition is essentially nothing. Okay. Hopefully that's helpful in terms of some background. And then these are just some fun images that I like, and WHI has lots of great resources as well that I'll discuss. But these are some of the sort of advertisements, if you will, about how folks in the US are trying to engage women in HIV prevention. So if you sort of reflect on where you might spend time in your role, I would say that there's probably not a space in which you can't have these discussions about HIV prevention. These are good discussions for outreach settings, whether that's shelter outreach, drop-ins, drug treatment, which could be, you know, OHT, detox, rehab recovery, needle and syringe program, supervised injection, overdose prevention, and then so many more, right? Any place where you might engage with women. I mean, I don't even think we can say vulnerable or marginalized women, right? Those might be the folks who we see the data on seroconversion, but that's certainly not everyone who might be at risk. And then, you know, don't forget about, for sure, refugee health, newcomer services, and unfortunately, we don't have any of those care providers here today, but also that we have many migrant workers in Ontario and Canada. These folks don't always have access to healthcare, and it's a really good example of times where these conversations are really important because they might be particularly vulnerable. I think it makes a ton of sense in sexual health services. And unfortunately, HIV prevention medication is not offered across all sexual health clinics in Ontario or Canada. And that's really unfortunate because it's a really good space for it. And then in my own work, I do a lot of hepatitis C work. I do a lot of hepatitis C work among women. And I always tell people, if you're screening for hep C, you should be having a conversation about HIV prevention, because the risk of acquisition and the power struggles that occur in terms of how acquisition happens are overlapping. These conversations are also really important in primary care and in women's health. So thinking about your primary care role and when you might do a PAP, you might be providing reproductive care, prenatal care, any kind of gynecological care. And remember, there's no such thing as age restrictions in HIV prevention, right? So if you have someone who is having sex, talk to them about that. What does that look like? Is this something that needs to be discussed, should be discussed? And I have really super good uptake among sexually active women in their 60s, in their 70s, and they want to talk about this. We should really be doing universal offerings, right? Part of the objective here today, I think, is to give everyone in this group the confidence and information to share, but that we're also appreciating that just because we give information doesn't mean that that's going to lead to uptake. So there are lots of virtual care spaces, phone-based options, but what we really need is really great holistic approaches in each community that include in person, right? Okay, so this is this lovely resource from OHTN that has just come out that might give you some thoughts on how to have these conversations and the types of questions to ask. If you're in primary care or if you're in a higher volume clinic where you have less time with folks, put these into stamps so that you have them in a way that's really accessible to you and you can have it at your fingertips. You might have some of these conversations around partners. This is really important in terms of how you're asking these questions and that you're asking permission to ask these questions, right? I can't emphasize that enough. So maybe you're exploring number and types of partners if that's a conversation that can be had in a space that's comfortable for that person in front of you. You might ask them how they meet folks that they have sex with, how they perceive their own risk around HIV acquisition or STI acquisition. You might ask folks about their practices, and sorry about the typo there. That could be types of sex. So where do you think you might have the highest risk in terms of HIV acquisition? Is that a vaginal exposure, a front hole exposure, an anal exposure, rectal exposure, however, whatever language you want to use? Sometimes this question requires more explanation, but you also want to be really considerate of gender and anatomical structures And so I think it's okay to explain what you're asking, like where would you have the highest risk? What type of sex do you have? You might ask folks about what they think about STIs, if they feel like they have high risk of STI acquisition. I sometimes frame it as, how would you describe your condom usage? Would you say it's always, frequently, sometimes, or never? Are you ever concerned about a condom breaking? Do you have negotiating power in terms of if you're using condoms or not? In the algorithm from the CDC, you saw that part where any STI acquisition, chlamydia, gonorrhea, syphilis, etc., should point us to discussing HIV prevention. So it's a good trigger for folks who are in clinical spaces. And we should think the same about viral hepatitis, so hepatitis B, hepatitis C. And then Lauren mentioned all the opportunities in terms of women's health, reproductive health that are really well suited. But the last P in the 5 Ps is pregnancy. So thinking about a time where women may not be using condoms because, you know, that piece around pregnancy prevention is not there, but that we should still be thinking about HIV prevention. So I'm going to share one study that's underway with our group. And just to give the proper acknowledgements to the person running this study, named Rafiq Van. So we're doing a cross-sectional questionnaire-based study. We've so far recruited 175 participants, and our goal is 300 who self-identify as sexually active women or women who use drugs, who have never used HIV prophylaxis medication. And I think so far, some of our most interesting data, because there's a lot of data with a 52 question survey, is that there's a bit of a disparity between people who list their risk factors for HIV in one way, but then self-report their risk in another way. So we've really looked at some of the questions related to acts versus self-perceived risk, and folks who we would think have higher risk acts, if I can use that term, actually have really low self-reported subjective HIV risk. So this is where education and teaching and awareness and discussions, and again, to Lauren's point, discussions over many times, right? How do we get a little deeper into these discussions? And then just again, some of our higher level data, we looked at awareness, and awareness is extremely low around PrEP, PEP, and PIP. Okay, another beautiful aspect of the OHTN guidance document around how to approach discussions is to use the ACT approach, which stands for avoid stigma, collaborate, and take your time. And I think these are really great teaching points if you have maybe 5 minutes with someone who's a healthcare provider that you're trying to discuss HIV prevention in women, to hand them this OHTN resource and also highlight some of these acronyms. And I'm going to pull back to say that this is a figure I already showed, but universally offering PrEP and PIP is avoiding stigma, right? It's like when we move to screening everyone for certain things, like we screen every single woman for HIV in pregnancy. That really helps to avoid stigma because every single person is offered the screening. And if we offered PrEP and PIP to everyone, that would really help to avoid stigma. Unfortunately, in certain provinces, PrEP is only allowed to be prescribed, or I guess I should say reimbursed, to certain populations. And that can be really, really stigmatizing. We're lucky in Ontario, that's not the case. When we think about that collaboration piece, we really need to talk about what people can expect. So these are some of the side effects as well as the impacts on your body. And I won't belabor these points, but it's important to know them and to really understand people's point of view around if they're thinking about medication-based prophylaxis, that there's going to be appointments, that there's going to be blood work, that there's actually a pill to take, and that going to the pharmacy might be a bit of a hassle and might not fit with their lives. So are there other options or supports that can be given there? we've done a lot of work to try to create what we call low barrier models. So in our model, these are self-referrals, and they can come through any way. They often come through point of care HIV testing programs. They've come from health units. They often come from peer outreach, including escort services. They come from community-based organizations and aid services organizations. And then sometimes they come from clinicians and sort of a more formal referral. I think it's really lovely if community folks can do a lot of the education to really see if medication-based HIV prevention is where people want to be, or if other prevention strategies are the preferred way. And then they don't have to go through the hassle of going to see the clinician or going to clinic. In our models, we've used NP-led models, RN-led models, RPN-led models, pharmacist-led models. We really try to work in the spaces and places where people might be, and then to also allow for phone or in person, and then do that comprehensive HIV prevention visit. I just also want to acknowledge that this is a windy road and has a lot of hoops to jump through, and we know that, and patients know that. And so that can be a really huge barrier for patients. These are geographical barriers, structural barriers. And so these are two settings which might make a lot of sense. Primary care, like a CHC, community health center, where there's a lot of programs already built in. And as I mentioned, a sexual health clinic, where that's sort of already being done in terms of testing, and it should be done in terms of offering. This should be in street outreach, this should be in drug treatment, and we should be flexible. We should acknowledge that if you're a regulated healthcare provider, our colleges have not caught up with the fact that we need to text patients. Sometimes we find them on Facebook. We need to be flexible on email. We understand privacy and confidentiality, but we need to be able to reach people, right? And so I was thinking about sharing two stories, but Cassandra, am I running out of time? Yes, I am. I'm always running out. Okay, I'm going to save it for questions. And then I just wanted to share some really nice data from South Africa and Kenya, where they've really looked at the PrEP user journey among women. The references below, you can also find a lot of these really nice images on AIDS Map to find sort of new studies around HIV and HIV prevention and care. But to show that, again, this is a journey. There's an uptake aspect. People have some happiness or feel stigma around early use. There's a whole piece around keeping people and women on treatment. This is specifically around women. When are times when women might want to pause PrEP? When would they restart? And then what does discontinuation and then again restart look like? I think in most types of care where we're trying to achieve one thing, we need an opportunity for care. We need someone to start talking about that type of care, and then probably we need some kind of clinician, right? These are tools that are going to be, I think, circulated anyways, but these are the WHAI, PrEP, and PEP. There's not the PIP piece yet, but you've heard a lot about PIP, and PIP is a way that we can be proactive, and it's really important. And then I'm going to share some data that we've looked at for hepatitis C among women in drug treatment, but not all of these folks had hepatitis C. We were just asking them how they would like to be cared for and what helps to enhance their care for any type of care. It was in the context of a Hep C study, but again, not all these women had Hep C. So we heard we need to have like an open door policy for future discussions. You know, provider attributes, no, and provider outreach worker, et cetera. No huge surprise, being non-judgmental, being responsive to questions, being available in non-working hours, being able to work with caseworkers, and that preferred methods high up there is email and text, as well as working with other workers or other healthcare providers in their circle. Sorry if I went over time, but thanks folks for listening.
Thank you. Okay, so I'm just going to go quickly over some resources. Tanya will be dropping a document into the chat that will have a list of all of the resources that we think would be helpful. It's not exhaustive. There obviously are more out there, but this is just a list that we have. They are specific to Ontario, so just keep that in mind. But we are providing this because service navigation is a key part of starting PrEP, PEP, or PIP, as Lauren and Mia have both highlighted through their presentations. And for a lot of service users, specifically cis and trans women, this can be an intimidating process. So navigating that this process with a trusted service provider can make all the difference between someone thinking about PrEP and actually starting PrEP, for example. So one example of a service tool that you can use to talk to your clients about PrEP is the Ontario PrEP website, which is listed in the document resource. This has information for folks who are thinking about starting PrEP, for folks who are on PrEP, as well as for folks who are prescribing PrEP. But this resource is really good in terms of determining if someone is right for PrEP. There's also a great tool called the Clinic Finder, which has a list of providers throughout Ontario who prescribe PrEP. So regardless of where you are, you can find a clinic or provider that is able to prescribe PrEP in your area. And specifically when we're looking at like financial barriers and concerns about how to pay for PrEP, there is a section on the website that looks at paying for PrEP, and specifically there is a program called PrEP Start, which provides 3 months of free PrEP for people who are at risk of HIV and who do not currently have drug coverage. So this is a great way to get folks started on PrEP. There is a form that providers would have to fill out, which we've attached to the resource list, but you can also find more information on the Ontario PrEP website in terms of how to start that process. There's also more provider resources, including research done by Lauren, as well as others in Canada, that look at prevention uptake, specifically PrEP and PEP in Canada for cis and trans women. We've also provided the fact sheet that OHTN has published in collaboration with our Women's Health Committee on PrEP for cisgender women, which draws on some of the points that Lauren and Mia talked about in terms of the 5 Ps and the ACT strategy, as well as other considerations to think about when asking, you know, is my client like a suitable candidate for PrEP? There's also the rapid response, which looks at awareness, accessibility, and uptake of PrEP among cis and trans women. This is a great resource just to look at what are some facilitators and barriers on starting PrEP for both cis and trans women. And even though this is in Ontario, like some of the findings can be used, you know, like nationwide.